Strategic Planning Committee meeting on Wednesday, May 21st at 5:35 p.m. Roll call.
Director Jeffries.
Here.
Director Acosta. Unavailable.
Are there any public comments?
No.
Okay, and we'll scroll down to discussion items. Great. Okay, I see some things on the menu here.
And these are both new items that haven't been discussed yet, and we were kind of waiting for strategic planning to occur before we brought them up for discussion.
Right.
So,
And oh, go ahead.
I'll jump into point A if you are ready.
Sure.
Okay. This one I briefly mentioned to you a while ago.
Mm-hmm.
And it came out of a group that I sit in that the county convened for rural health questions, concerns. So a lot of the rural communities in the county came together with a county representative. Oh, sorry, Kat.
Pretty.
She's big.
She is. She's like a Maine Coon cat with her long back.
So sorry, Kat. They came together, and basically the conversation over the last few meetings, the last few months, has been how can the rural communities have more access to healthcare? And there's obviously, we all know the same challenges, small population, often some lower income, challenges with transportation. So one of the final conversations, we had VCC come online, as well as a different FQHC that supports the East County area. And one of the things that came up was, could these FQHCs, which now all have mobile clinics, could they come out to the rural areas? And the number one challenge is that unless that rural area has a number of patients' lives who've signed up with that FQHC, a mobile clinic in their area doesn't do any good unless they're part of that system, right?
Right.
So that's like saying the people in Duluth or Rainbow or Bonsall, equestrian, agricultural areas, we can't just say, hey, we're going to send, a VCC or a Fallbrook Family Health Center or neighborhood healthcare. You can't just send their mobile clinic out there and think that that's going to be able to do it. Folks have to be able to sign up for it. So the conversation was, what if the FQHCs were on a regular schedule? Every third Tuesday, FQHC A showed up in Rainbow, and then on Wednesday they were in Bonsall, and then on Thursday they were in Duluth. And every month it could be counted on for those folks to be out there. The folks on the call said that that would probably work. It would take a little bit of time for the community to realize, okay, I've got this access, I need to get signed up. So that could work. The challenge, of course, is money. And the FQHCs, their component of that is, well, if we send a mobile clinic out there and it's not, the appointments aren't full, we lose money. And
right.
That's why they don't just randomly send them out there. So before I went any farther on the conversation, my thought was, if we, the district, are motivated to provide access to those rural areas, we could put together an FQH or an RFP for one of these FQHCs to guarantee. They'd have to say, all right, it costs us, and I have no idea on the numbers, this is just spitballing. If it's going to cost us $5,000 every visit until we have 25 appointments a month, and we anticipate it's going to take us 1 year to build to that capacity. Is that something we are interested in exploring to make happen, knowing that we would probably have to underwrite those unfilled spots until that FQHC can have enough patient load to fill that service on a regular basis?
Thank you. And I remember the FQHC was discussed during our LAFCO meeting with the consultants.
Yeah.
It's a special designation that
Yeah,
allows.
a federally qualified health. Yeah.
Yeah, I get it. I get it. I get it. Okay, so this is a little bit like other conundrums, which is, are we going to put money into something over time that may not work out? Right? You know, I used to live out in Duluth at the 12-mile marker. People come into town all the time.
Yeah.
Vallecitos is right by the freeway. I mean, I know there's backcountry, but it just doesn't resonate with me that there's a big enough population for the first Tuesday of every month to come and talk to a doctor. It doesn't ring like possible. But
for Duluth, probably not. The population is smallest for that group. For Rainbow or Bonsall, potentially. Rainbow specifically, even though they're by the freeway, transportation for that community is incredibly limited. So that would be the one area I would say, if we were even going to consider it or pilot it, that would be the one spot once a month that it goes out to.
Seems pretty thin to me, my initial response to it. And then they've got to wait till the next month to get a follow-up. And then, I don't know. I mean,
Well,
I think we should keep it in the mix. Part of strategic planning is that good ideas compete with each other.
Yeah.
That's part of strategic planning. And so I'm glad it's here for us to think about, because the strategic plan, which should be a 3-year plan, and I hope we'll be able to manage that, is meant to unify us, mind and thought and act, and also help us know where our finances and people power is going to be allocated over time. Because every new idea means some existing idea might get less attention. Mm-hmm. So that's how it breathes, right? And then, of course, measuring progress is a big deal. So I just want to contextualize this, because this is a good example of something that rings really true for the few, that we have to decide. Did you say $5,000 a visit? We'd underwrite?
No.
You use the 5,000 for something.
We don't know what the price would be.
Okay.
So without putting out an RFP, we really wouldn't have any idea what it could potentially cost them. Yeah.
Does anybody from the group that you sit in have any roundabout cost ideas?
No, because in this group, there was too many community groups and not enough FQHCs to start that level of conversation without building a
expectation
sky concept. Yeah.
I was going to say, because as we try with the partnerships for urgent care, it would be good to get a rough estimate, like, in the case that one doesn't work out, at least we have this one also in minor works, or at least rough estimates. Mm-hmm. I mean, not in RFP, obviously we can't put that out there, but
I did sit in the meeting today, Rachel, and San Ysidro was talking about their mobile unit, mm-hmm. and a partnership in Julian taking over a clinic, but apparently they have 4 mobile units. So they might have some ideas. I know we have connections, we had connections with them, maybe to ask, maybe they would be able to give like what the cost is. And they were talking about the same thing you're talking about, trying that out and requesting it. And
there was a lot of conversation from that rural roundtable. The problem with San Ysidro Health is they have such a bigger presence that their costs may not be equitable to VCC and or to neighborhood. neighborhood healthcare is probably most on par with their size.
Mhm.
VCC has been in this group in these
Mm-hmm.
meetings. So I was tempted to reach out to them and just see, like, could you give us more idea?
Mhm.
Is True Care in Escondido and Valley Center?
I know they're in Escondido. I haven't seen them in any of the rural areas, but I'm not sure.
Hmm.
I think we'd have to reach out to all of them to see who's willing to play. And this unfortunately leads back into the same trap that I stumbled into back during COVID when neighborhood healthcare pretty much gave the same spiel that I'm hearing from all the rest, which is they have unofficial territories and they try not to go into each other's territories unless there's a demonstrated need. And right now, Rainbow falls under the Fallbrook Family Health Center.
Mhm.
So
my thought is on this topic to keep noodling, but we need to put it on the table with the other things, new initiatives that we might take up as well as maintenance of others. And it may sustain itself and it may fall right off because we want to be serving the most people we can. And we aren't a doctor desert. I know some people may think we are, but we aren't. I mean, there are physicians up and down the 15, not exactly, how would I say, convenient. But anyway, I want to keep it on the table because it has a ring to it. I just don't know what the ringtone is at this point. So any reconnaissance without too much effort that you get, throw in the hat so that when we come back to revisit it, we can know more things. Does that make sense?
yeah. And I think that this falls in line with something that you'll see it, Jennifer, because it's coming to you from Alex. It's probably time that we have a real conversation around either another community needs assessment or a much longer term, strategic plan that isn't just based on, construction of the wellness center. I know we've talked about that part.
Yeah. We're ready to know more things for sure. Yeah. So let's put that down here for a minute. Okay, and is this a renewal of the MOU?
No. So for B, Hospice of the Valleys, they started their bereavement group with us with a grant 2 years ago. They did not renew the grant. They didn't apply last year to see how things were going. The group has grown considerably since then. Teresa can talk to the numbers, but we've seen really good feedback from people attending that group, and we're seeing a lot of growth and steady attendance in that. So in order for us, I think, to keep a bereavement support group going at that, this is one of those programs I'd rather move out of grant world and into MOU world so that we can own it and keep it consistent.
Okay. And makes sense. Forgive me, I'm not pulling up the figures. What is the census around the bereavement support group? What is it like? Is it 20 people, 15 people?
It's anywhere from 6 to 12 people, and they like to keep it at 10 and under because of the nature of the group. And it is, people are in it. It goes for 8 weeks, takes a break.
One group at a time. Okay.
Goes for 8 weeks, takes a break, does another 8 weeks, and we see people cycling through it. So,
all right, and the MOU-ness for us would be to provide the space, right?
No, to provide some financial support. So it would allow us to provide them about $8,000 a year to make sure that we've got their bereavement support counselor on site for about 40 classes per year. Each one's about an hour and a half. And this pretty much would cover, any potential supplies, all the various things that they bring in for these groups.
So we're replacing the grant that they didn't apply for again?
Yeah, it's actually considerably less than the grant was. The grant, they tried to do a few other things that were more hospice care specific. And that part is more their business plan and didn't fit what we really want. What we're seeing movement from is the bereavement support program. And that allows anyone, whether they've been on hospice care, through Hospice of the Valleys, it doesn't matter. Anyone
Right.
going through that process, then
Bereavement. Mhm.
yeah.
Okay, well, I put this under the category of maintaining current services for sure. Not as much of a strategic thing, but a maintenance thing.
I mean, it fits with the
No, there's no doubt that it's a match. There's no, I'm organizing my thought process between strategic thinking and maintenance, so I'm placing that under maintenance, and we wouldn't want to, we obviously have data that shows it works and people are appreciative. Do we have a count of unduplicated people? In other words, a group of 8 meet and then one person leaves but comes back later? Do we have, with that small group, we could be keeping unique users. There could be a list of people that we could know, oh, okay, over the year, there may have been 120 sessions and it served 35 people. I need to know that data.
Okay, so here's our challenge, and we knew we were going to get to this point. Teresa and I've talked about it a little bit. As we're starting to try and capture this data, just using sign-in sheets,
I know.
we don't have a way to track it. So
we've already been through that part. I know.
yeah,
We
so
have to start thinking how.
we might need to start thinking about investing in a CRM,
Yep.
client relationship management software.
Right.
And I have kind of put it on hold, and Teresa and I've talked about it, and Event Temple doesn't, which is our scheduling software, doesn't really
Right.
have that built in because they're very different needs. But I think it's time we're going to want to have it for not just bereavement, but for chair yoga, for
Everything.
for-
No, I'm at the point now after 6 years. I love hearing that 1,200 visits have taken place down there. I want to know how many people.
right.
Because that matrix, that ratio is important for us as a public entity. If we've got something that's serving 10 people and something else competing that needs to be expanded, we have to consider that.
Yeah.
It's about level of service. So could there be some work done, Judith, probably, to pull together the cost of that kind of, is it software? Should I be saying software?
Yeah, it would be software, and we're probably talking an initial $10,000 to $20,000 to get into
Okay.
a reasonable CRM.
Okay, could that be put together in a proposal to come back here at our next strategic planning? Because that is really strategic planning data. So that my committee and me and Cindy can forward a recommendation to the board. Yeah, it's time to crack the egg open, make an omelet. Sorry, Judith, to put something on your desk.
No, I was gonna say, do you guys have 3 that you guys have discussed, Rachel and Teresa,
No.
that we can go out?
And actually what would happen is Teresa and I are probably more familiar with this style CRM than Judith. So we'll probably look for
Whoever.
a few, and then we'll in-house identify how to dissect it. But it's definitely time. When I went to the last AFP conference up in Seattle, I really looked at a few different things. Teresa and I have gone down this road before on CRMs. So we know what questions to ask for them.
Yeah.
So yeah, we could absolutely bring it forward, because I agree, with all of these various service levels coming forward, it's time to grow up on our data.
Yeah, we're ready. Okay, thank you.
Yeah,
Thank you.
and unfortunately, neither beach cities nor really any of the other districts have a good option, because none of them are really doing it this way.
Yeah. Well,
So we
I'll
can
count on the
find
crack
you.
staff to crack the code.
Yeah.
Okay, now, on the MOU with Hospice of the Valleys, let's make it a recommendation from the strategic planning committee, because we're part of expanding transference of programs to MOU status rather than grant status,
Mhm.
that we recommend that we do that support
Okay, so
at
what I'll do-
$8,000 a year.
Yeah, I'll bring forward, remember, just as a background, Alex provided us with new contract templates. So I'll build it into that template for us to be able to start moving forward, so you can, we can just start seeing a very consistent pattern of
Mhm.
how these things are done. And do you want
So-
to bring that to the June board meeting then, or just move on from the recommendation from?
Yeah, I won't be there June 11th.
Well, keep in
If
mind,
you
it
want-
doesn't,
If you think my
it
voice
doesn't
is
have to
needed.
go, it doesn't have to go through the board any longer. It's just been if we wanted to.
I think that kind of thing should go to the board,
Okay,
so they know where our money is going. See, they don't live it like you do.
right.
And then we get a question of, how come, when did we say do $8,000 for bereavement counseling, Yeah.
Right.
I would bring it.
Okay. So
And although I won't be there, say that it came out of strategic planning committee.
but we'll have the minutes from the meeting to do that.
Okay. All righty, thank you for those. Can I blue sky with you all for a little bit? As we prepare a strategic plan that has measurable goals.
Yeah.
As we know, it's been an ongoing goal formation and hitting the goal for the wellness center, and we're now ready to do a little more layering on that. So it seems to me that we have reasons to have strategic goals in facilities, program development, community visibility, serving demographics, and the launch of our foundation, our nonprofit, right? We've got our nonprofit status now.
Yes.
Okay, and maybe we don't want to do anything in 25, 26 with that, but I want to get it on the thinking list. Because we did it for a purpose to do I imagine to go out for more grants through that.
To have a funding vehicle for programming. And
Okay.
more options.
Yeah, we're not gonna do a gala though. Relax, everybody. Relax, relax. Okay, just from my board member perspective, and I'm checking in with you guys now because I'd like to start penciling out a 3-year plan. Relative to facilities, do you feel like over the next 3 years, this building is pretty set, except for the boundary adjustment?
Yes.
We're pretty upgraded and pretty, thank you for that, okay. So down at the Health and Wellness Center, if we think of 25, 26 as year 1, is that the year when we'll see the kitchen taking life?
Probably finishing construction. I'm not sure if it'll be finalized for programming, but it should be nearing.
Phase 1 of it will be done?
Mhm.
Okay, so that's a good 25, 26 facility goal. What is your feeling on what I'm calling the parsonage? Do you see that being a 25, 26 ADA bathroom thing? No?
No, it's gonna be 26, 27, because we've got to finish building A.
Okay, what are we calling that? Not the
Building
parsonage,
C.
what do we call that?
Building C. We're really creative.
Yeah, very creative. And so that includes that area, the landscaped area behind that could be upgraded, that'll all be done in 26?
Potentially.
The temp meditation garden that you've thought of to back there.
Potentially. That
Okay,
would probably have to come in after the house is completed, because you're gonna have equipment under there.
it's kind of an ancillary thing anyway.
Right.
When do we think the sanctuary would be on the runway to some sort of help? Do we see that in 26, 27 or?
I see that
Thanks.
somewhere between 25, 26 and 26, 27. With the new plan, once the demonstration kitchen is done, A is primarily, it's not structural the same way it was going to be. It's more the addition of a couple of different doors, switching out windows without moving structural
Structure.
walls.
Yeah.
You know, it's more cosmetic. I mean, there's
Okay.
some plastic surgery for sure, but it's more cosmetic.
Eyebrow
than it is-
lift.
Yeah. It's an eyebrow lift. It's a neck lift. There might be a little lipo in there.
Okay, so from a 3-year plan, getting the kitchen done, doing building C, beginning and ending on the sanctuary, somewhere between 25 and 28.
Yes.
Okay. Now that feels like a right bite to me. Does that feel like a right bite to you guys? Okay. All right. In terms of programs, I'm wondering if during 25, 26, we can do some thinking about 2 things. Well, about 1 thing. We've done nothing on childhood obesity, nothing. And I'd like some thought being, yes? Nothing that's, okay, tell me what you're going to tell me. Maybe I missed something.
We haven't rolled any programming out, but we have just been included in grant funding, which we're about to get
Okay,
from Jay Moss, Skinny Jean, our diabetes folks. They just finished a preliminary on the Family Healthy Weight Program, which is,
Good.
I got the name right, didn't I, Teresa?
You did.
You
I'm
did.
proud.
The Family Healthy Weight Program, which is essentially wrapping what we know of as DPP, but expanding it so that it includes that whole family unit,
Good.
which
That's
DPP
exactly what I
does
want.
not do. Yeah. So they've
What-
done a lot of the exploratory programming outlines, being able to work with CDPH as well as CDC on developing this program that can be integrated into family, but is built upon the strengths of the DPP program as it exists.
Yeah.
So taking that clinical evidence, building it so that you have it for that youth and child component. We haven't talked about it yet because we haven't seen their results and their initial kind of curriculum outlines.
Okay,
But we, the district, Fallbrook, will be getting a $30,000 check from Skinny Jeans as part of the grant funding that they received because they're using our DPP program as part of the pilot data.
excellent. Okay, so this will come back to the next strategic planning meeting with all these details?
Hopefully we'll have more details. It may not, oh wait, because we're doing it in 2 months, we should have more data by then.
Or whenever, it'll come back here and we'll go ooh, ah, over and go yummy, yummy, yummy. Okay, love it. That is so funny because I have written here, family involvement.
Yep.
So this is a fortuitous thing.
Yeah,
And
and
so
we've talked with Marlena since day one.
Yeah.
That this was a concern, that it was something that, you know, our board had an interest in. She explained that they had a long interest as well, but there just wasn't good programming out there.
No kidding.
The programming that had been school centered was just abysmal.
Can't do it.
Yeah, because without
I mean, we can be the ignition point and do some things once we're doing things.
right.
So I can't tell you how happy I am.
Yeah. So I didn't want to launch that as an initiative because we're still waiting for details. But
Yes.
we knew that it was an initiative.
Love it. Okay. The other urgent public health issue right now is the spike in colon cancer in young people. It is huge. You read about it every day. I would like to do something in 25, 26 to push this information out to the community. I mean, yeah, 25, 26. We need a campaign to raise awareness because it's frightening what's going on. And they're finding out all sorts of things that happened through nutrition when they were kids. There's just a lot going on here. I think we should have some information nights. We just need to be part of the messaging there locally because it's very drastic. I don't know whether you guys are picking up on it or not, but the figures are, and breast cancer in young women.
Yeah.
That's another spiking thing that's going on. I mean, to be 30 and have colon cancer. So can we put that in the pot to think about?
Yeah,
It's
it's
probably a
obviously gonna have to
Jasmine.
be, I think that we can probably partner in with county to a lesser extent, but to CDPH as a much larger extent. And now that we have at least a few connections over there, we might be able to lean on them and see what they've got and what they're rolling out. And see.
I'd like to count that as a win 1 year from now, that we really push the message out in a variety of ways. So if we could look at that.
Sure.
And Teresa, I have a challenge for you.
Okay.
What kind of goals should we set over the next 3 years for Spanish language programming?
That's always something
We
we're
gotta bear
looking
down
for.
on it.
Yeah, yeah,
I don't know whether, even though they didn't get funded, we still have our community outreach health workers,
yes.
okay? Could we get them in a room and have them tell us, what are the top 3 things you think we should offer? And have we already done that?
We've been working with them on that, yeah.
Okay, but that's, working
Yeah.
with them on that is different.
Yes, we have a meeting coming up with them.
Okay, and is the outcome of that meeting going to be 3 specific areas they feel we need to develop? Or how are we gonna know what they're thinking?
They've been working with the community, so they should have some insight for us. They've done a couple
Beautiful.
of listening sessions,
Okay.
so they should be able to present that information.
Okay, and why I keep saying 3 is the magic number in strategic planning land, because organizations can manage 3, right? But I would really like us to declare in 25, 26, 27, 27, 28 goals around Spanish language offerings.
Keep in mind, and one of the things that we are going to have to do, and Teresa, to her credit, when we went through budgeting this year, we've already allocated some funds, knowing that we are going to have to pay.
Yes, we're gonna have to pay people. Yeah,
So
you're
just
gonna have
so
to bring them
we're all-
in from wherever.
Yeah, we're all clear. We've already
Beautiful.
shifted the initial conversation of taking those resources that were low-hanging fruit. Teresa did a great job finding people at county and different places who could bring us services for free.
Right.
But to now expand beyond that, we're going to have to go to find, research, and pay, and some of that's already been done by Teresa.
Yeah.
Providers that we can contract with to provide those services in English and Spanish. Not all the programs are available in Spanish because they don't have facilitators, educators. So
Right.
basic groundwork, I'd say, is there. Identifying the things or the 3 most relevant. Teresa, if you want to build that into your conversation with them. And if, just something to consider, Jennifer, if VCC and the Promotor program says we don't have capacity to do more, we might want to consider saying, all right, what do you need from a capacity standpoint to help develop this alongside us as a partner? That's an area we can fund because we don't have to have it be in the grant program.
Right. No, I'm totally interested in that. Thank you for having already made the shift to, we're gonna have to pay people to come do this. That's an important mind leap, right? Because we're like, where are the volunteers? Where's the county, you know? Okay, well, I'll be interested to hear what they say. Would you add a 4th bit of the conversation? Ask them how we can get the word out about colon cancer and breast cancer in the 30s and 40s range. To ask them, because people without a medical home are particularly vulnerable to this. And they don't know the symptoms. They have the ick factor. They don't want to do any kind of intervention with the lower part of their body. So ask them, how can we help people know? And then we'll be on the right track. Right now, it's like nobody is paying attention. Those who are okay. Enough said, Jennifer. Thank you.
Well, and Jennifer, I'll add to that. I'll talk to the folks over at Michelle's place. Obviously, they're dealing with all cancers.
Yes.
See if they're hearing or having or building into any of their strategies about more youth cancers.
Great, okay. Love that. Let's see. I am judging by your response to me on the nonprofit thing that it's not really a sizzler. Should I take that off? Okay, goodbye.
I would say yes. It is gonna be built into our culture to go ahead and know that that is always part of what we're doing to help supplant opportunities for programs, opportunities for the district events. So the two
Yeah.
district events that we already talk about, trying to find a way to build the foundation to generate some funds for that, or to use the foundation for collaborative grants with our nonprofits, if and when the state and or national are at a point where they're providing funding again.
Gotcha. Okay, that makes sense. It's like a sidecar right now.
Yeah.
You know,
It's right
we'll
there
be with you
us.
in a minute.
It's right there with us. We're dragging it along with us.
Bling, 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 bling.
Yeah, it's just not really able to lead anything yet. Plus,
Yeah.
most foundations need about 3 years of history before private funders will take
Get
a look
interested.
at them. So,
Yeah. So let's go back to the community needs assessment for a minute and flesh that out a little bit more. Although I appreciate the assessment that was done and I feel that it was right on in terms of conditions that need attention in the community, the methodology was a little funky to me. I would like to think through a more local assessment firm to do that assessment because they know about California and they know about rural and they know about Latino populations, et cetera, et cetera. So can you ask around what other organizations are using for these kinds of community needs assessments?
yeah, we can look for a local contractor vendor.
And when I'm saying local, I'm thinking Southern California. I'm not thinking, you know, right here. We don't need North Carolina coming in and having to explain our world to them.
Right.
That's not nice.
Right. No, I heard you on that.
Well,
one.
the first thing we're gonna do is map out all the churches. No. I mean, it was pretty awkward there, but anyway, new day, a new day.
You know, we had a very different goal for the
Yes,
last
we did.
report.
That's fair.
There was a very different set of goals. I think this time we can be much more focused in the kind of data we're asking them to provide to us.
Yes.
And we have a good idea now of how to identify programming in our region. What we need from them are what are some of the emerging health trends? What are some of the demographic trends? What are the heat maps that have specific disease, illness, morbidities, those kinds of things? And that's a more, I think, traditional health-related community needs assessment.
And with enough lead time, we can get the appropriate people from the school districts to sit at a table and talk to them and unpack what they're seeing on that playground or whatever. We also can get the older teens involved more. That was a disaster trying to get them gathered to talk to them. So anyway, I'm glad we're gonna do this. I think it's yummy. I'm a favor of assessments and get the data. And that'll be really cool. And maybe we can do it even at the beginning of the new year so it impacts thinking for budget.
Yeah, it depends how long it takes them to get it done, how long it takes us to find the right partner. But
yeah, if we could
to have that data before the 26-27 budget.
Yeah, exactly. Maybe we could get this puppy out the door. Would it be an RFP?
Oh yeah.
Okay, maybe we could get this RFP out the door by the end of September.
No.
Why?
Because it's going to take a lot longer than that to draft that with a few of the other things we've got going. That would be
October.
maybe October, November.
Okay, then it's not gonna work because Christmas, the holidays, we'll be back into getting a needs assessment for 26, 27.
I mean, the first groundwork we have to do are find the kind of contractors that are doing this work,
Yeah.
and build that RFP around what data are we specifically asking for. So I mean, I
Would
can
we
start
build,
building.
would we be willing, you know, UCSD and CSUSM do these kind of community assessments with faculty who know how to do it. Refresh my memory, an RFP would be required under what circumstances? Level of cost?
It's not so much level cost, because it's a professional service. It
We could
doesn't have specific requirements. It's a best practice to either ask for a request for qualifications or a request, an RFP. So either way, we have to put forward a document that says what we're looking for, which we can do. That's not the difficult part, but it's also making sure we ship it to the right sources so that they can put together a proposal for it. The challenge here is that I did not budget for this type of report in this fiscal year.
Yeah, but don't you think we need it in this fiscal year? Can we wait another year?
We can wait and have it be done and ready and launched in 26, 27.
Okay. I'd rather do it with the right timeline than rush it.
I'd like to.
I don't see why.
I'd like to take this fiscal year to really outline with Teresa the programs we've got, the information we've got, really outline what we may find from the Promotoris and VCC or any of the other groups specifically. I'd like to build that data into our RFP so that we're very clear when we go out to a contractor for community needs assessment that we're saying, you know, don't just give me more soft data around our senior population or our traditional.
Yeah, we already have a census. Okay, so we're gonna view the assessment ramp up as this year, an RFP ready to go in the spring of this year to inform our budget and people power allocation beginning in 26, 27, 28.
26. Or 26, 27, sorry.
Well, no, that's when the assessment would be done.
Yeah, okay, yes, sorry.
It won't impact anything until 26, 27.
Yes.
That's the power of the 3-year look. It gets us real. Okay, yay. Did you all have anything else in the strategic planning bucket that you needed to get out on the floor here?
I had
Did we
no
get
other buckets or pillars.
Okay, so did we get the right things explicated and people are thinking about them and are we good?
I think we are. Teresa, anything from our conversations on programming?
Nothing is coming off the top of my head.
She's
But-
still in
yeah.
K-Town.
Kinda. Just on, in terms of the role that diabetes plays and combating that in our community, along with having this healthy family weight program, we're going to be among the cutting edge communities having a 3-tier approach to diabetes. And this is like the new upcoming, method for communities where we will have the prevention part, we'll have the childhood part, and we'll also have for type 2 diabetes.
Yeah.
So when we get
Nice.
this childhood one, and we're gonna have the most robust programming that's out there for communities.
I
So
love that.
that I think somehow probably fits into the strategic planning that we're
Oh,
continuing
yeah.
to work on diabetes.
Well, whatever the models are that are evolving, the more we can model them instead of just going for reduce your ALC1.
Yeah.
Okay, there's this whole other nugget that we're gonna get into. That's great.
Yeah, so that would be we would be cutting edge with that, but.
Well, keep your razors clean, girls. Okay,
We're being surgical.
I know you are. All right, are you all ready to go home?
Thank you.
Adjourn.
Thank you, Judith. Thank you, Rachel.
Bye, kids.
Thank you.
Bye.
Bye.
Oh, he looks like mine. She looks like mine.
Sweet.
Oh.
She wants nothing more than to get down right now.
Okay.
I'm
She
done
wants
with the
to
meeting.
We'll do her own thing.
All right. Good night, guys. I'll see you tomorrow.
Good night.
Bye-bye.
Bye-bye.
See you tomorrow.
I'll